Let's start the meeting and go now live to India. Dr. Sivakumar has live cases.
Good morning, Ziad. Are you able to hear me?
Sivakumar, good morning.
Good morning. Are you able to see me and hear us?
We see you and we hear you very clear. And first of all, thank you for making the long journey from Mashhad to Dubai back to Chennai yesterday morning. I know that it was very difficult for you guys after they closed the airspace, but now you are in front of us. Go ahead.
Thank you very much, Ziad. I would like to thank Ziad, Ahmed, Damian, and the entire team of PICS for giving us this opportunity to be participating in this wonderful meeting. We have two patients scheduled. In the first schedule, we have a pulmonary valve implantation. With me, I have Dr. Pramod Sagar and Dr. Tejasvi, who are my colleagues for the last few years, and Sister Christy, who is our scrub nurse. And I have Dr. Uday Kumar, who is our intensivist, who is managing the patient on general anesthesia. I would like to request Dr. Vandana, who is my colleague, to move the slides so that Dr. Pramod will introduce the case.
Good morning, everyone. I hope the slides are visible. Our patient is a 24-year-old gentleman. He is a case of tetralogy fallow with pulmonary stenosis, which was diagnosed at around 2 months of age. At 9 months of age, he underwent a right modified BT shunt, which was in 2001. Then, after 2 years, he underwent a complete surgical correction with a transannular patch in 2003. He was asymptomatic, and for the last 6 months, he has developed class 2 dyspnea. His weight is 68, and clinically he was having a to and fro murmur at the pulmonary area. Echocardiography showed free PR. There was flow turbulence at the RVOT, and the peak gradient was 28 mm mercury. The branch PAs were large. There was significant RA and RV dilatation with mild RV dysfunction. Next, please. The chest X-ray, you can see here, there is significant cardiomegaly. CTR is almost 65%. There is otherwise there is no major issues. We can see some sternal voids we will be using for as a landmark during the procedure. Next, we can also see that ECG also shows broad QRS with a QRS duration of almost 180, which is also an indication for a pulmonary valve implantation in this case. Next, we can see the CT here. The CT, if you see, it is actually a hourglass shaped RVOT. We can see the proximal and the distal RVOT, distal MPA is quite large, and in the mid MPA there is a fold of tissue which is likely the previous valve tissue that is there, and the measurement in the narrower segment is around 24 into 31, whereas the proximal and distal dimensions are quite large. You can see almost it's 38 and 45, which are quite large for any kind of valve. The RCA was safe, it was anterior as we can see here. The LAD was in relation to distal MPA, which was roomy, so we don't anticipate a major problem with the LAD. However, we'll do an interrogation during the procedure. This is a platform called VMSI, which we have been using from last 2 years. We have to thank the this is a software from Poland. This we can see in this we can actually go and slice. We can get a 3D model. We can slice it. We can see over here. We can see the dilated branch PS. We can see that the tissue infolding over there, and that is the narrowest portion where we have to land the valve. And the proximal and distal is quite RVOT is quite large, and that is the LAD as we can see here. Can you go to next slide? This is the segmented model. We have only segmented the RVOT with the LAD for our evaluation. Here we can see that the waist is quite, it is almost circumferential, and also we can see the LAD here, which is actually at the in the relationship of posterior wall of RVOT. To simulate the procedure, we were if we take a valve, we are planning to take a my valve. I will tell about it later. This is a valve which we are planning actually to get something like a diameter of around 33.5, which is actually 32 valve with additional contrast. Now, if you take a 33.5 valve and 2 centimeter, which is actually around 2 centimeter length in a full diploid position, if you go and place it in the exactly in that position and see how the opposition is, it looks like the opposition was good. Here we can see here the all round, if we rotate and see, the opposition was nearly good, and it was it was looking adequate, and also the coronary was looking safer. It was distal to the valve. Next slide, please. This is an image again which shows the same, and in the third image on the right side you can see that the coronary is actually safe when the valve is fully deployed. Next slide, please. We can also derive the angiographic views which can actually show the RVOT well. In this actually we can see this is the only view, that is the LAO30 with clearness 55, which was actually giving a good picture, but that is not feasible in the lab to perform. So we will be using whichever is more closer to this image, and we can that we will show in subsequent angiograms. This is actually just a few slides on the my valve, which is, for those who don't know about this, this is an Indian made valve. This is a nickel cobalt, which is actually initially made for the aortic valve, but now we have been using in pulmonary valve for more than 5 years now, and almost more than 100 patients in India have undergone pulmonary valve using this my valve. Next slide, please. It's available from 19 to 32 millimeter, and this 30.5 and 32 are called XL, which are quite large sizes. And recently a 35 is also under evaluation. The system that is used for delivery is called a navigator system, which is mainly derived for an aortic valve, but also it will be helpful in the pulmonary valve position. Next, please. There is a dedicated sheath called a Python sheath, which is actually a 14 French sheath, which is universal for all the size of the valves. The good thing is it's called Python because it can bulge and it can expand, and it has an expansive character. It can, when the valve is being pushed, it will bulge and then actually come back to its original dimension when we pass the valve. So that is what we will be probably using. And Python XL is one of the sheath that is a longer sheath that can be placed up to the branch PH so that we can spare the tricuspid valve, which is being available now. This is the case, and we will be planning to use the pulmonary valve using Merrill valve today. Thank you.
Thank you, Pramod. I think it was a wonderful presentation. Ziad, this is as Dr. Pramod was telling, a significantly dilated right ventricular outflow tract, and the landing zone was only a fold of tissue that was coming out from the outer surface of the right ventricular outflow tract. The distal main pulmonary artery was close to 4 centimeters, and the ventriculo-pulmonary junction with the transannular patch area was also almost 39 millimeter. The fold of tissue is what we are trying to capitalize on. So what we
Sivakumar.
Yes.
Sivakumar.
Yeah.
We have some questions before you start. So
Yeah.
my first question to you, I don't know if I missed it or not. Have you done an MRI for volumes and all of this?
No.
Because
no,
I have not seen it in the school.
Yeah, see, this patient is coming from Sri Lanka. The patient has very significantly dilated right ventricle on the CT scan and on the echocardiography. Okay. We could not do a cardiac MRI because cardiac MRI facilities are not available in Sri Lanka. And the patient arrived yesterday morning into our unit, and we did not have time because there was also some uncertainty about how I am going to reach back from Iran back to
Sure. That's
India.
okay. I understand. I mean, we all agree that he has significantly dilated right ventricle, and I'm sure if you have done the MRI, it will. But actually, from scientific and academic point of view, it's important that when you do these cases, because these are high-stake cases, any complications, anything like that, if you are not working with guidelines, you could have a problem. Let me ask the panelists here quickly before you proceed. Choice between self-expandable versus balloon expandable valves. Zuhair, any comments on this patient from surgical point of view?
Well, the only thing from surgical point of view is the fact that the distal pulmonary arteries are very dilated, almost aneurysmal. So I just wonder if percutaneous valve, what will do for those pulmonary arteries, which I think at one stage they'll probably need some sort of intervention, because I believe that they'll probably continue to dilate, and I think they needed to be dealt with. So personally, such a patient, I would have recommended surgery as the treatment of choice rather than a percutaneous balloon.
Good perspective. Thank you. Go ahead, Regina and Erkan and.
I think this patient has a large RVOT, self-expandable valve also will be a good option for this particular case. Maybe my valve has a special big valve. We don't have good experience with my valve. We'll listen to our colleagues here and see what he will do with good luck, inshallah.
Regina, go ahead.
To me, it's the same as my neighbors just stated. Yeah, we would have explored this for a self-expanding valve in our team.
Yeah, I agree, Dr. Ziad, and the entire panel of moderators. This anatomy is suitable for Venus P36 by 25 valve, or it is also suitable possibly for a harmony. Both these valves, Venus P as well as Harmony, both are available in India on import license, which means we have to get a special permission from the Indian government, whereas my valve is available on shelf. And since my valve has got an option of 32 millimeter diameter, and when we inflate 5 ml extra, this 32 will almost reach 33 millimeter. So we are planning to use a balloon expandable, but I completely agree with the panelists that it is also a case for a self-expanding valve.
Shivakumar,
Yes.
one question from the audience here from the floor. Alejandro.
Hi, Shiva. This is Alejandro from Argentina.
Hi.
Great case as always. In this case that you are thinking about implanting a my valve, have you considered creating a landing zone with a stent, with a previous stent to make that right ventricular outflow tract more predictable?
Exactly. Yeah, I think it's a very good point, Alejandro. Whenever we have a huge RVOT and a non-obstructed RVOT, it is always good idea to have a pre-stent. But the diameters that we are talking about is a little more than 30 millimeter. And technically, we don't have large stents that go up to 32 millimeters in our place. The options that are available are 10 zig CP stent that can be done, or Andra XXL that can be done, and these are not available in our place in smaller lengths. They are very, very long and they will be protruding for long distances. So we are planning to go for a direct implantation. I will show you with the angiogram how we selected our landing zone. Can we
Go
see
ahead,
the
Shivakumar.
Yeah, first picture. So what we started off with is LV angiogram, just to exclude any residual ventricular septal defects. Even though echocardiogram did not show, there was a previous echocardiogram done few years before which were mentioning about a small residual ventricular septal defects. We just wanted to ensure that. Next one, the access that we took was right femoral vein, left femoral vein 2 catheters, and left femoral artery. Through the left femoral vein, one of the catheter is used for pacing the right ventricle, and one of them is for giving the control angiography in the right ventricular outflow tract. Through the right femoral venous catheter, we have advanced a Lundquist wire, parked it deep in the right lower lobe pulmonary artery branch. And this is a marker pigtail that runs on the Lundquist, and parallel pigtail catheter is making the injection. You would have seen that Dr. Pramod also mentioned during the virtual reality reconstructions that this RVOT was getting profiled only better on a shallow left anterior oblique cranial projection. However, we started still with a RAO angiogram. This was the RAO angiogram. In this RAO angiogram, we can see that the narrowest point was getting hidden between the aneurysmal part. Second picture, I'll show you all the pictures. Okay, freeze it now. So here, if we have a look at it, go back. We can see that the lower waist is the ventriculopulmonary junction, which was very, very large. Then there is an aneurysmal, one transannular patch that is on the leftward side of the RVOT. Just above that is the second narrowing, which is the fold of tissue that we are planning to use as the landing zone. Can you now run this angiogram again? So if you look at it, the superior, the indentation is what is going to be our landing zone. As was pointed out by the surgeon, the branch pulmonary arteries are quite good. The distal main pulmonary artery just beyond the point of the waist is also very roomy. As well, the proximal transannular patch region is also very roomy. So we need to be very precise in our placement as we are expanding the valve. Next picture. We also tried a lateral view. However, the lateral view was also, it was getting overlapped. So we decided that the shallow LAO cranial will be our the prime angiogram. Can you show the fixed photos of the measurements? We will now show you the measurements now that we have done in all these three views. Show the recorded. Okay. So this is in the epicranial, the sort of shallow LAO cranial projection where we are getting almost 3 centimeters on the region of the waist. And show the other photos as well. Okay, so this is in the same projection when we are seeing the distal main pulmonary artery pre-bifurcation. It was almost around 36 millimeters. And the level of the transannular patch, the bulging transannular patch, it's around 35, and the ventriculopulmonary junction was around 37. So what we are planning to use as the landing zone is between the first line and the second line. The next picture, the other measurements. Okay, so actually primarily we are now going to use this as the landmark. We then subsequently show the next angiogram. So we did a balloon testing, balloon interrogation of the right ventricular outflow tract using a 30 millimeter semi-compliant ZMED balloon. Can you run the picture? Next picture. Next. So this is a ZMED balloon which is 30 millimeter in diameter. Despite RV pacing, the balloon was slightly getting milked into the right ventricular outflow tract. So this was much more distal than what we anticipated. Next picture. So at this place, when we made an angiogram, we realized that it is the proximal part of the balloon is actually at the level of waist and at the level of landing zone, and there is still a small amount of residual flow. So the next picture, we slightly pulled it out, and this is now we are able to clearly see the waist. This is a 30 millimeter ZMED balloon which almost has fully inflated. We are able to get a complete occlusion. So the sternal wire, below the second sternal wire and above the third sternal wire is going to be our potential landing zone. So once we have got a complete occlusion on a 30 millimeter balloon, we started preparing for a 32 millimeter valve. At the same time, we also prepared ourselves for a coronary interrogation. Next picture. So this is another check of a 30 millimeter ZMED balloon. Here we reduced the pacing in order to find out whether without pacing the balloon is popping out too much. We found that the balloon is reasonably stable there. Next picture. So this is a balloon interrogation. The coronary catheter has gone deep into the left anterior descending coronary artery. We can appreciate that when we are having a full inflation, there is not much of narrowing of the left main or LAD. The left circumflex is flowing poorly because the catheter has got deeper into the LAD during this particular angiogram. So currently what we have done is we are live with the hemodynamics. We want to show the hemodynamics big. I want to show you one PA pressure and RV pressure. So this is now catheter in the pulmonary artery. This is recording a pressure of around 30 millimeters systolic with an aortic pressure of almost 95 millimeters. The patient is on general anesthesia. I am now pulling back the right coronary guide catheter which is over the Lunderquist wire. Now this has come up to the pulmonary main pulmonary artery. The pressure is more or less the same at around 30. Now I am coming down. This has now reached the right ventricle. This is about 30, maybe 32 to 33. I'm coming down further. This is below the ventriculopulmonary junction.
Less than 5.
So this is around 35 millimeters of mercury. And now we are at the right ventricular inflow region.
Hi, Siva. This is Ahmed. Yeah.
Hi, Ahmed.
Yeah, good case. Congratulations. I would like to comment about the sizing. Yeah. I don't do with semi-compliant balloon interrogation before sizing balloon because it may cause a little bit enlargement in the alveoli because of the pressure. But with compliant balloon, you don't see it. Maybe the waist may occur less than, for example, 28 millimeter. Then you may put lesser sizes of the valve, maybe directly, maybe after breast stenting. Another issue, the coronary compression test. We have given up coronary compression test in native alveoli for a long time. After 50 cases, we have done more than 250 cases of coronary compression test in native alveoli. We haven't seen any. So we gave up. Another issue that in this particular patient, are you gonna to put a stent or without stent? In last 5 patients we have done, especially relying on the CT angiography. We cannot rely on the on the angiographic imaging measurements, I do believe CT angiography more than conventional angiography. What do you think about this?
I agree, Ahmed. I also trust more on the measurements on CT, less on the angiographic measurements. And about pre-stenting, I mentioned about the problem of not having an adequate sized large stent to almost go to 30 millimeters. So we are directly going to be planning a pulmonary valve. Since we are about your sizing balloon, Amplatzer sizing balloon, which is a very compliant balloon, versus ZMED balloon, which is a semi-compliant balloon. I trust ZMED balloon very often in almost all the native RVOTs, because that definitely tells me that the right ventricular outflow tract is completely occluded with a 30 millimeter balloon, and that gives me a reassurance to use a 32 millimeter valve with 5 ml extra, which makes it around 33 to 33.5 millimeters. So that gives me enormous confidence that the valve will be fixing at the landing zone properly without any significant paravalvular leak, or a lack of adequate contact of the valve with the outflow tract. So all the cases I use a ZMED balloon. And pre-stenting is done only in patients who are less than 28. If it is more than 28, we don't pre-stent, we directly go for the valve. So in this patient, what we are planning to do is exactly identify that same landing zone and try to deploy the valve. Now this is the navigator system with a 32 millimeter valve that has been loaded. And can you concentrate? So this is the small loading sheath. This loading sheath has got the valve inside. The valve is positioned in such a way that the proximal skirt, what I'm touching here is the proximal skirt. The proximal skirt is the polyurethane cuff around the valve, and the distal part, which is going to be on the main pulmonary artery, is the bare portion. So in the valve, we will have almost 50% of the valve will have a covered segment, and the distal 50 millimeter will be a bare segment. So this goes through, this navigator system goes through a 14 French expandable python sheath, and the python sheath slowly expands to allow the valve to go inside. We pre-dilate the python sheath with a 18 French dilator, so that the dilator
Sure.
is, yes.
Do you have dry seal sheet?
No, we don't have
Or-
dry. We have,
Yeah, are you gonna directly, yeah, like Tev, yeah?
no, we are using the same python sheath. You see the, this is the python sheath.
Yeah, it is not long sheet, you know.
Yeah, it's not a long sheath. Actually, Dr. Pramod was mentioning, we have another option of a Python XL sheath, which is a long sheath, which goes up to the right ventricular outflow tract. However, that sheath has 26 French. So we want to try it on a conventional 14 French sheath itself. So
I don't use dry seal sheet as well, yeah.
We-
Yeah, I haven't seen any significant problem during the tracking of the valve, in my opinion, yeah.
yeah, we don't have an
Yeah.
dry
No,
seal is not
yes.
available in our country. It's not registered in our country. So now what
We
we
are
are,
not in our country as well.
yeah.
Carry on, please.
So now the sheath goes in the delivery sleeve. Now we are advancing the valve. The valve now,
Do you need pacing? Yeah, yeah.
I'm keeping
I
a
don't,
tape.
yeah, you are gonna do pacing, yeah?
Yeah,
I don't think it is needed in RVOT,
yeah,
in my
correct.
opinion.
So
I
now,
haven't done.
what I'm going to do is, we are trying to, we'll check the wire position once again. Show the right, okay, wire position is more or less stable. Come back. Okay, so now
Can we see the lateral projection as well?
we have, it's a single plane lab. So if I will choose a lateral plane when I need it. Currently I am advancing through the tricuspid valve.
Can we see the right anteroblique projection, yeah?
We'll show it. Ahmed, just
Yeah,
see
that's
what
good.
fluorostore this and then show me. Fluorostore this.
Yeah. Do we need the coronary coronary catheter at the aorta?
The coronary catheter is just sitting in the ascending aorta. We will be
Just
using it at the time when we need it. So currently now we have advanced the, I'm loosening the track. I will advance the, show me the guide wire position. It's okay. So now I come back to the RVOT. So now the pigtail catheter, come go to that same LAO cranial projection. Get ready for an angiogram, 18 ml at 18 rate. So our landing zone was below the second sternal wire. So at this position what I am going to do is slightly withdraw the assembly. So at this point let me make an angiography. You are ready at 18 at 18? Full cranial? Yeah. Okay. So let us review this angiogram. In this angiography, almost 80% of the valve is beyond the place where it's in the main pulmonary artery, and just about 10 to 20% of the valve is within the proximal to the landing zone. So our plan will be to pull the valve a little bit more as we are expanding. So we are going to go for an extremely slow inflation. So we probably will inflate only the proximal part and the distal part of the balloon and slightly make the valve go a little bit above. Repeat another RVOT angiogram. Again assess the waist. The waist, as we see here at this point, is just below the second sternal wire. It is roughly in the region of the left coronary artery catheter. So this left coronary artery catheter plus the second sternal wire are going to be our tentative landmarks for judging the guide wire position. So this is the tip of the left coronary catheter and the second sternal wire. Just below that is the landing zone. Show the previous angiogram. So our intention will be to come a little bit more proximal. However, that will be after a little bit of balloon inflation. At this point, we will also test the RV pacing and see whether RV pacing results in a better quality angiography, because there is going to be stasis of the contrast more. So pace at 180, pace at 180, and get ready for an RVOT angiogram 18 at 18. Okay, now repeat an angiography. Okay, stop the pacing. So here again on a pacing angiogram, we identify that the waist, the landing zone is below the tip of the left coronary artery, and it is below the left second sternal wire, and somewhere between the second and the third sternal wire.
Sivakumar,
Yes.
I think this is a great position there, because when you inflate, the valve tends to go a little bit lower. So I would not come down more than this, because you're going to inflate it to 32 millimeter, and definitely it will be below the bifurcation. Ahmed, what do you think?
Let me say my tricky. If I do direct implantation of the my valve, I start a little more distally inflate, because it is opened from the distal end. And
get ready with an injection.
to the left ventricle is heavy. So
Here,
not only come down. If you see the flared distal, and then you can come back little bit and do an injection. It is not possible to milking back to the RV, because it will flare start at the distal end of the valve.
Okay.
So you may start very slowly, then little bit back, and then do another angiogram and go up, in my opinion.
Yeah,
Go ahead, Sivakumar.
Yeah, I agree with you, Ahmed. We are going to follow something similar. What we are going to do is start pacing now. We are going to have a minimal inflation, like start pacing. Yeah, minimal inflation. Minimal, keep inflating. Yeah. Stop. Hold it. Hold it.
Stop,
Now
stop,
get ready
stop,
for an
and
angiography.
do
Get ready
another
for
angiogram.
angiography. Okay. We are still a little above.
Little
So
bit above, yes.
little bit above. So I am slowly bringing it down. Get
Little
ready for
bit,
a second injection. Okay.
yes.
In,
Slowly inflate and to see.
okay. Okay. Now keep inflating.
Slow.
Yeah.
Okay, go.
Yeah. Go full. Go full. Empty. Empty. So this is a volume dependent inflation. So we are trying to empty it, fully empty, fully empty. Okay, deflate, deflate, fully deflate.
There is,
Now fluorostore this.
there are
Stop
indentation in
pacing.
both sides, so very well,
Stop pacing.
just in the middle of two
I'll
valves.
show you the
Very well positioned.
fluorostored sequence. Show the fluorostore. Show the fluorostore fully. So
Can you put an
like
angiogram?
now I'm going to do a coronary testing now. This is the full inflation. The entire ml 45 ml, actually it is recommended 40 ml, we gave 5 ml extra. 45 ml has been implanted. I'll get it hooked, the left main catheter.
I think no need for extra volume in this particular. You see the indentation on the valve. You may know that the outer diameter of the 32 millimeter S3 and my valve is more than 32 because of the skirt. At least additional 2 millimeter.
Angiogram
more.
ready?
Means that 34.
30 ml at 18 rate. 30 ml
Even if
18 rate. Or 23 ml 18.
I would have used. No problem.
Ready? Okay. So freeze that picture. So if you look at it, we have caught, actually this is not a beautiful angiogram because the RV is diluting the picture. However, we have seen that the position what we desired is what we have achieved. Completely deflated.
Excellent position.
Yeah. So now at this point, what I'm going to do is give a slack on the wire. Give a small slack on the wire. So that it moves away from the valve.
Oh, very good.
I'm coming very slowly. Come back to AP position, please.
If
So
anybody in the audience has questions, we have three microphones. They are distributed there. May, you have a question? Go ahead.
Morning, Shiva. It's May from Egypt, and congratulations on a very good case. My question was not using the dry seal because we too have a problem getting it in our country. So, how easy it is to track, and how have you encountered any problems with the tricuspid valve? And I think Dr. Shalaby also says you don't use the dry seal. So, is it if you use a self-expanding valve or a balloon expanding, any problems there?
I share with you most of the countries like Turkey or Egypt or ours all are having more or less the similar problem of non-availability of a large 26 bore sheath. Currently, the 26 bore sheets that we have, a few in our country are the Medtronic Centrant. The second option for us is when we are using the venous P valve, the venous has got a Vitae sheath, which is also a 26 French sheath, and then we have the Python XL sheath, which is can you go back to that epicranial projection? Python XL sheath, which is again a braided 26 French sheath. However, in majority of the patients, we try to take it directly. I will briefly tell you the way in which this one is different. My valve is different from a Sapien. The sapien, the my valve has got a proximal portion of the balloon and a distal portion of the balloon. And if you look at the inside of the balloon, there is a conical one rigid hub. This conical rigid hub increases the profile of the proximal and the distal part of the balloon. And between the two conical hubs, there is a waist, and in that waist, the valve is crimped. So the valve does not, the valve's nickel cobalt metal ridges do not protrude outside this conical part of this balloon. So the smoother part of the balloon goes through the tricuspid valve, and the my valve, which is the nickel cobalt alloy, is protected inside because it is smaller in profile than the conical upper part and the lower part. So the chances of having a significant tricuspid valve trauma as we are advancing through the tricuspid valve is to some extent avoided in this valve. The long sheets, we use it if we fail to achieve a proper valve position on our conventional method. So at this position, I want to show the RV and PA pressure traces. So I am now going for.
Thank you, Shiva, and congratulations again.
Yeah, Mai.
Yeah, I can make.
Sivakumar, you have about 5 minutes to show us the angiogram.
Yeah.
And then
I will show you
China.
first the hemodynamics. Show it in 50 scales. Both in 50 scales.
Question there.
Regarding the
Make it a big screen.
regarding coronary artery compression test, especially if you're expecting from CT, there's abnormal course of the coronary system. Maybe it is too early to skip this. This
Go to your
step,
caudal
especially-
projection.
Especially, I mean, now, still we have different size of the valves and different model of the valves. So what is the best to test? Is it to do like an aortic root angiogram or to do selective coronary angiogram, especially if you are expecting very close proximity of the coronary artery to the RV?
Good question. So Sivakumar, you heard the question about coronary compression test.
Yes.
Which is better to do, selective coronary angiography or aortic root angiography?
I always do selective coronary angiography. I'm just getting, while I was hearing that question, I was getting into the caudal projection to see an en face view of the, we always do a selective coronary
What do you do?
angiography.
Aortic root or selective?
So this is now a coronary angiography. Now show the
Selective coronary
hemodynamics.
angiography is the best, I think.
So this is the hemodynamic result. We can see that there is a good amount of diastolic holdup of the pressures. You can see the pressure tracing.
Yes.
Yeah. So now I am going for a pulmonary artery angiography. So go to the same epicranial projection. Epicranial projection. Elevocranial. So now get on to main screen, fluoroscopy. So I'm planning to make one injection through this marker pigtail. Go further, okay. Reduce the LMO. Let us see the valve in its. Yeah, keep reducing. Reducing further. Yeah, keep reducing further. Enough. Okay, ready for injection.
Congratulations.
Very nice, Sivakumar. Very nice result.
Yeah, make a measurement quickly of the. Make a measurement of the valve, the diameter with the marker pigtail. I'll just show the diameter. We in fact we gave a 32 millimeter and we gave 5 ml extra. So it will be. In fact, I heard Dr. Ahmed also mentioning that since the balloon testing was 30 millimeter was occlusive, it may be acceptable even to go to 30 millimeter and 32 itself. However, we just will see how much we have gained by that additional 5 ml. Yeah. So
So this is 31 millimeter.
31 millimeter, correct. So
That's perfect.
This is 32 on the top. So basically 34 at the distal. So basically what we see is, even though we give an inflation, there probably will be some amount of tiny recoil of the whole assembly. And also the distal right ventricular outflow tract might press the valve a little bit. So it is we get a comfort by inflating a little larger than the recommended balloon size. So we have here seen that instead of 40 ml, we have inflated 5 ml extra, and probably we achieved just a contact of the valve with the entire outflow tract in a very stable position. Do you want another
Great.
RVOT angiogram again?
No, I think you have demonstrated the valve position, the function, no PR. I think the result is excellent, and we congratulate you on this. So we're going to leave you now, unless if there's a last minute question. Ahmed, do you want to say one word about the, you said coronary angiography, aortic root or selective? Quick.
Yeah, usually for saving time, aortic root. If there is any suspicion, go on to select.
Likewise, I do aortic root if there is any suspicion, and then I go with selective. Sivakumar, well done. We'll see you for your second case. Thank you so much.
Thank you very much. Thank you very much.
Thank you.